Okay, how to return. Okay. This perfect storm actually started with a sunny day in the beautiful Aswan city, when we have a referral call from nearby hospital that they have a 64-year-old gentleman, diabetic and hypertensive, presenting with inferior ischemia and RV infarction. Actually, we thought it is a quick BCI before lunch, but this never happened. After gaining radial access, we faced marked subclavian tortuosity, marked difficulty in engagement of the left coronary artery. But after repeated trial, we managed to do coronary angiography for the left system, which revealed proximal and mid-LED significant lesions. Repeated trials to engage the culprit right coronary artery, but we failed. There is no one-to-one movement of the catheter. And then we get back to the arm of the patient where we realized the cause of this, which is there's a kink at the catheter. After repeated trial to cross with the wire, even with guide wire, we failed. And actually we realized that we have complete fracture of the catheter. After gaining femoral 8 French axis, we tried to snare the broken catheter, but it failed. If we remember the shape of the catheter in the previous image, it is like the handle of umbrella. It is got stuck at the almost a radial loop. So we do an injection that reveals that we have maintained the flow around the catheter to the arm. So we forgot something. We have a patient with a STEMI. So we back to the right coronary artery, engaged with the Jotkin right, crossed with a BNW wire and BTCA, but we have TIMI0 flow. And at this moment, we have another strike from the storm. The patient arrested in VF with ROSC after DC shock and 1 cycle of CPR in a heart block. So we inserted a temporary pacemaker. We injected intracoronary tirofiban, repeated manual aspiration using the export advanced catheter with slight improvement of the flow, but still we have Hebes thrombus burden. In our center, we have a mechanical thrombus aspiration device, which is AngioJet. We used it in this patient with improvement of the distal flow. At this moment, we have a catheter stuck in the patient arm, so we voted for stopping at this stage regarding the coronary and deferred stenting and back to the catheter. But by this time, we have our cardiothoracic surgeon in the cath lab, and he revised the study with us. And he said that he is familiar with this situation during harvesting the radial graft during the bypass surgery. So it took him about 5 minutes to do small incision and get the catheter out. And here's angiography after extraction of the catheter, revealed maintained the flow to the distal tree in the forearm of the patient. On the next day, the patient was weaned from mechanical ventilation support, regained the normal sinus rhythm, and temporary pacemaker wire was removed, maintained on tirofiban for 48 hours, followed by enoxaparin, and fortunately, his ventricle was preserved. After 3 days, here is the control angiography. I remember at this moment, I asked my consultant, should we go left radial? And he stared at me. Are you kidding me? Go femoral. And here is the control angiography, and we ended with proximal stenting and distal DCB. Then a stent for the left anterior descending artery, followed by non-compliant balloon, and there is the final angiogram. So the learning point from this case, radial axis is good, but not a holy axis. Know when you should stop. Teamwork is important in complication troubleshooting. Expect the storm, even if it seems a sunny procedure. And thank you.
Thank you very much. I just have a couple of questions and comments. So that's a great case. So one thing, before your catheter fractured, did you try to grab the distal tip with the snare and then try to unwind it in the arm? Did you ever get an opportunity to do that, or it just cracked right away?
We did something related to this concept, was external fixation directly on the arm of the patient. But at this point, the most important thing is to remember what is the last movement of the catheter. Was it anti-clockwise or clockwise to reverse it? And actually, in this scenario, never you recall what is your last movement.
I see. And one other question, just a thought. I think at one point when you were trying to snare it, you could see your two catheter ends were pretty close to one another. I've never actually done this, but I did read about a case where they took a coronary wire and wired into the entrapped catheter and inflated a large balloon and used that to pull it. So I don't know if that might have been another option.
Actually, this might work if we don't have the umbrella-shaped kink in the distal trapped catheter, which is hooked inside what is like a radial loop. So even when we got the catheter in the snare, we can't move it at all.
Okay, I see. Yeah, so it was hooked there in the
yes.
arm. Okay, thanks. Any comments from the panel?
Yeah, so it's, in my experience, the problem usually occurs if you continue to wind in one area, and this happens with these very tortuous vessels. I find that a stiff wire sometimes helps to turn the catheter better in that situation. A big breath, obviously, for the patient, that also helps. And not to turn in the same direction multiple times. I think that's what causes this. I think you feel a difference if you're trying to unwind it as to whether you're winding it further or not. And you can just also see on the fluoro. So those are just some of the things, otherwise if you get stuck in that situation, well done and nicely managed.
Thank you.
Comments on the panel? Tony, sounds like you've got a comment?
We had a similar case, actually, so I thought this would never happen to me, but we had a catheter break off. I think you did exactly the right thing. You had a lot of clot in the right. You got a catheter stuck in the arm. For our experience with the surgeon was the same. It took him minutes. This was super easy for a vascular surgeon or a cardiac surgeon to make a small incision and pull that catheter out. You can, I think your idea of wiring and putting the balloon or snare, like you tried to snare it, those will work, and we've had to do that, but this case, you got other problems with a STEMI and a lot of clot.
Yes.
And then you wait a few days, the clot's cleaned up, so it's kind of bonus for your intervention.
Yes.
And your arms had a little time to heal. So I like that approach of not spending too much time worrying about the arm. Just let the surgeon have the arm later, fix the STEMI, and come back a couple days later.
Where was the incision he made?
Just at below the forearm line, at just 1 centimeter below the elbow.
Got
Direct.
control and was able to then remove. Got control of the artery and then was able
Yes.
to remove.
Yes.
Great.
And I take it that the surgery was done post-STEMI in the OR. The patient went to the OR and had surgery, or was it done in
No,
the
no,
cath-
on table.
on the table
Yes.
before the STEMI intervention?
Patient already mechanically ventilated after the cardiac arrest, so he's sedated. So just direct insertion.
I don't know how many surgeons will touch that in the U.S. with Tirofiban going and stuff like that. So.
All right, any other comments? Thank you, really interesting case, perfect storm. Hopefully the weather is better.
Thank you.